Hi there. Thank you for joining me today for this virtual judging of this poster. My name is Glen. I'm a third-year resident at Scripps Mercy Hospital here in San Diego in Hillcrest. The other authors on this poster are Carol Castro, another third-year medical resident, and special thanks to Gavin Jackson, who is a physician specializing in endocrinology who oversaw this case. So this case is titled Cushing's Syndrome Secondary to Ectopic ACTH Producing Tumor Presenting as Apparent Mineralocorticoid Excess. Little background, neuroendocrine-derived small cell lung cancer can present with several different types of perineoplastic syndromes. Furthermore, ACTH secretion in particular carries a poor prognosis, which is thought to be secondary to hypercorticolism and subsequent risk of infection. This is a particular case of a 78-year-old man presenting with a chief complaint of, quote, "I feel like I suddenly got old," end quote. He originally presented with progressive shortness of breath, lower extremity swelling, dry mouth, fatigue, and polyuria. Note the patient does have a long history of tobacco abuse. His past medical history included prediabetes, asthma, hypertension, and alcohol abuse. Examination on arrival was noted for marked hypertension, diffuse and expiratory wheezing, and 3+ lower extremity peating edema, but otherwise was unremarkable. The laboratory studies initially revealed severe primary metabolic alkalosis with a VBG pH of 7.62, a bicarbonate of 50, and a PCO2 of 49, and severe hypokalemia of 1.8, raising a suspicion for primary aldosteronism. So in discussion, this combination of marked hypertension, severe metabolic alkalosis, and severe hypokalemia is definitely a concern for primary aldosteronism. However, aldosterone levels returned at 4.7 nanograms per deciliter on repeat with concomitant low primary renin activity of less than 0.1 nanograms per milliliter per hour. Given this fact that we ruled out primary aldosteronism, rare syndromes of apparent mineralocorticoid excess were considered. History was negative for licorice ingestion. However, 24-hour urine-free cortisol was very elevated at 28,280, with a high ACTH of 717, consistent with ACTH-dependent Cushing's syndrome. Incidentally, during his stay, the patient developed chest pain and underwent CT calcium scoring, which revealed lingular mass. A dedicated CT chest abdomen pelvis revealed a lingular mass, 2.5 centimeter, as well as multiple liver lesions suspicious for metastasis. Patient then underwent IR-guided liver biopsy, and results of the tissue pathology revealed small cell lung cancer. Chemotherapy was subsequently initiated. He was also started on spironolactone 100 milligrams daily, and his metabolic alkalosis and hypokalemia resolved, with improvement in his hypertension. He was considered for ketoconazole treatment to prevent steroidogenesis in the setting of his hypercorticolism and Cushing's syndrome. However, unfortunately, developed chemotherapy-induced hepatitis, making this less feasible. However, it was suspected that the ACTH-producing tumor would be susceptible to chemotherapy, with reduction of ACTH production. At this point, the patient was discharged from the hospital with plans for additional chemotherapy and a follow-up with endocrinology to taper his insulin. ACTH and urine-free cortisol levels did decrease significantly on follow-up. Despite this, unfortunately, the patient did continue to decline and was found unresponsive at home. The patient was brought to the hospital where he expired from cardiac arrest, unfortunately. In conclusion, a triad of hypertension, metabolic alkalosis, and severe hypokalemia, and a negative workup for primary aldosteronism should raise the suspicion for apparent mineralocorticoid excess, in this case of ectopic Cushing's syndrome due to small cell lung cancer. I thank you very much for listening to my case, and I appreciate any questions. Please feel free to contact me at fader.glen@scripshealth.org. Thank you.